Welcome to the Optimizing Medications to Support Patients Through Care Transitions conference call. My name is Jason, and I will be your operator for today's call. At this time, all participants are in a listen-only mode, and later we will conduct a question-and-answer session. I will now turn the call over to Ross Gatsky. You may begin, sir.
Good afternoon. I am Ross Gatsky, and we want to welcome you to today's Transitions of Care webinar, Optimizing Medications to Support Patients Through Care Transitions, presented by the Lake Superior Quality Innovation Network, or LSQIN. Lake Superior QIN is comprised of three organizations: MPRO in Michigan, Medistar in Wisconsin, and Stratus Health in Minnesota, to support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement. Successful care transitions are a team effort, and pharmacy is a crucial part of that team. Collaborations between pharmacists, physicians, care coordinators, nurses, and residents allow patients to benefit from a multidisciplinary approach to managing their health and recovering after hospitalization. This webinar features two multidisciplinary transitions of care practices and the contributions from different practitioners that made them possible. This session is being recorded and will be available in about 2 weeks. The PowerPoint presentation is a WebEx handout located under Event Material. We will remind you how to access this and our previous recording at the end of the session. All lines are currently muted during this webinar. We will have time for questions and answers at the end of this session, so please make note of any questions that may come up as you listen and respond to the group, or you may use the chat function during the presentation. This is a Learn All, Teach All webinar, and we would like all participants to share at the end of this presentation. Let's begin by being fully present and engaged. And with that, we will go into the speaker introductions. Our first speaker today is Amanda Schrepfer, and Amanda is a medication therapy management and clinical staff pharmacist for Goodrich Pharmacy. She graduated from Creighton University in 2010 with her doctorate of pharmacy and completed a residency with Goodrich Pharmacy the following year. She currently provides medication therapy management services and health partners clinics located in Elk River, Andover, and Anoka, and staffs with Goodrich Pharmacy in Anoka. She is a resident site director for Goodrich Pharmacy, helps process and coordinate learning experience for the student pharmacists at Goodrich Pharmacy, and volunteers as a preceptor at the Phil's Neighborhood Clinic. And our second speaker today is Callaway Van Epperen. He's an ambulatory clinical staff pharmacist at Frederick Hospital in Milwaukee, Wisconsin. He graduated from the University of St. Thomas with a Bachelor's of Science in Biology in 2009, and from the University of Minnesota with a doctorate of pharmacy in 2013. He completed a PGY1 community pharmacy residency from Frederick Hospital in 2014 and a PGY2 ambulatory pharmacy residency the following year from Frederick Hospital. He provides clinical pharmacy services in a variety of clinics at Frederick Hospital, primarily in the hospital discharge care program, as well as the sickle cell clinic and the metabolic clinic. And with that, I will turn it over to Amanda to begin her presentation.
All right, thank you. So like they said, my name is Amanda, and I'm a pharmacist that works at Goodrich Pharmacy. And I'm here to talk to you a little bit about our transitions program that we just started this year. And we're going to talk about improving healthcare continuity of care across the continuum. So here's some learning objectives for today. So we want to identify the role that pharmacy may play as part of the healthcare team and helping manage all those medications during transitions of care. And then also the strategies that we use to initiate and sustain that cross-institutional collaboration. And then the last thing, we're going to touch on is challenges and steps taken to overcome challenges that may be faced during transition of care collaboration. So before we talk about the transitions program, I really just wanted to start off by giving a really good definition of what it is that we do every day when we see patients. It's referred often times to as MTM, or medication therapy management. You may also hear it referred to as comprehensive medication management as well. But it's really just a comprehensive, step-by-step way that we're actually reviewing all patients' medications and assessing them for appropriateness. So the first step that we do when we see these patients is assessing all of their medications. And when we say all of their medications, we mean every single thing that they take, including prescriptions, medications, over-the-counter medication, herbal products, maybe even medications that they're getting from their neighbor that they really weren't prescribed. So everything that they're taking, we're looking at. We're assessing for appropriateness, effectiveness, safety, given the patient's comorbidities and other medications, and if the patient is able to take that medication as intended by the prescriber. When we're assessing medications, we also include an assessment of the patient's medication experience. So this includes talking to them about their beliefs and concerns about their medications or their disease state, and then also understanding expectations about their medication. So what in their past has influenced how they take their medications. So for instance, maybe they had a family member who was on insulin in the past and had a really hard time maintaining blood sugar. That may influence their willingness or kind of their comfort level with insulin for themselves. So just talking about that with them and helping them kind of understand where they come from as far as medications are concerned. We also assess all of their past medications. So what have they tried in the past for different diseases or different conditions? And what happened? Why did they fail? Or why was the reason that maybe a medication was stopped or changed? The second step there is identification of medication-related problems. So really we're looking at all of those medication and assessing, like I said, for appropriateness. So is it the right medication for this patient? Does it need to be renally dosed? Is there the right indication? Is there an indication? Is it appropriate medication for their age, for their other medical conditions, or for a lab value that we have? We also look at effectiveness. So is it effective? Is it doing what we want it to do? Are they meeting their outcomes or their goals for their therapy? And then labs too, we assess that as well in that. So if it's intended to lower the blood sugar, can we see that with their readings at home that they bring us? We also talk about safety. Again, lab, is the medication that we're giving for one condition safe with all the other medical conditions that they have? So we assess that as well. And then the last thing we really talk with them about is adherence. So are they taking the medication appropriately? Are they taking it at the right time? Are they taking it every day? And a lot of that comes down to barriers. So we really talk about barriers for adherence with patients a lot. So is it a medication that's very expensive and they just can't afford it, that maybe we can switch them with something else that would be more affordable for them? Or maybe they're not taking it every day because they think that, they are prescribed a medication for their blood pressure, and then once that medication, once their blood pressure gets to goal, they think they don't need to take it anymore. So really kind of trying to assess why they are adherent or not adherent to medication. Then the third step is developing a care plan. So we do that in collaboration with the patient and their other healthcare members. So really we're reaching out to their other providers, physicians, nurses that they may speak with, all the other providers that are helping care for them, and talk to them about what we think needs to be done for the patient. So developing any changes to medications that we think needs to be made, that can be initiating medication, maybe changing to a different medication, or sometimes just discontinuing medications altogether. I also talk about, in that care plan, identifying and establishing goals for each of their conditions. So really being clear about why we want the patients to be doing what we want them to do. A lot of times we tell patients, you need to check your blood sugar, but we're not really telling them why that's important or why it needs to be done. So talking to them about what the importance is for each of these things, and then also what their goal is. So what do we want their blood pressure to be? Why do we want them to weigh themselves every day if they have CHF? And then we determine appropriate follow-up plans for follow-up time for each action plan that we come up with. During that last step of follow-up, we basically meet with the patient again and see if the intervention that we made actually fixed the problem that we were intending to fix. So did what we intend to happen actually happen? During that time, we also talk to the patient about any new medication-related problems that may happen. So maybe we changed the medication during the care plan, but now they developed a new side effect or a new problem with the medication. So really kind of making sure that if we're making changes, it's positive. So that's kind of a little bit about medication therapy management and what we do as pharmacists on a regular basis when we're meeting with these patients. So I did want to start talking about our transitions program. So just to give you a little background about who I am and what, the company that I work for. So Goodrich Pharmacy is an independently owned community pharmacy practice located in the northern metro suburbs of Minneapolis-St. Paul. It's currently 6 locations, and it was established in 1884, so they've been around for a very long time. Collaborative relationships with local clinics and providers began in the 1980s. So we really started those relationships really early on with these providers and have maintained those relationships throughout the year. Throughout the years. So, this is something that we really think is important to collaborating with other healthcare professionals, is maintaining a professional relationship with those people. Pharmacists began providing MTM services in the 1990s in the community clinic. And then actually in 2010, we actually were asked by the local clinic, so the Health Partners Clinic, to provide MTM inside the clinic. So the physicians really saw the need for this service to be provided inside the clinic and asked us to provide this at least a few days a week for their patients. Currently, the pharmacists at Goodrich Pharmacy see patients in the community pharmacy and at the Riverway Health Partners Clinic. They're usually seen by pharmacists. We have a pharmacy resident as well, and then also student pharmacists help us out as well. And in the community pharmacy, most of our patients are referred by insurance companies or self-referred, so patients kind of self-select into having problems or having concerns about medications and ask to be seen by the pharmacist. On the clinic side, most of our patients are referred by doctors, so or other providers that we work with. So they're identifying some kind of problem or issue with either medication or the fact that the patient hasn't been able to maintain their health care goals, and referring them to pharmacy at that point. So I mentioned the resident, and that really has played an important role in our helping establish and expand our MTM services that we provide. The resident, just like a medical students complete residencies after their medical school, pharmacists also have the opportunity to complete a residency program. So our resident actually completes an ambulatory care-based residency program, and that residency helps them prepare and helps them learn how to see patients in the community and the ambulatory care setting, and learn how to do the MTM steps step by step. Every year, our resident is asked to do a project to help improve the patient care process at our site. So this year, our resident really has done a lot of this transition work because this was her project. So we sat down at the beginning of the year and discussed what we wanted to do for her project, and she said that she was really interested in transitions of care and wanted to kind of establish some kind of work with transitions of care. We had reached out to local hospitals in the past and asked to do a collaborative relationship with them to work on transitions of care, but hadn't really had much luck in the past. So I said to her, we'll try, let's see what we can do, but we're not guaranteed that it's actually going to happen. This year we took a little different approach so that we actually, instead of just reaching out to the pharmacy director at the hospital, which we had done in the past, we actually identified who the residency director was at the hospital and then who the residents were that may be interested in some of this work. And so that was really an effective strategy for us to kind of identify the appropriate people. So the pharmacy director obviously thinks it's a good idea to kind of work on transitions of care, but she's not the one that's really doing the work on the floor. So she wasn't the one to help us get the ball rolling, whereas the resident is the one that's kind of doing the grunt work, and so they're the one that has really helped move this project forward. So a little background, I want to start kind of before I start talking about the program, just about why we decided this needed to be done. So I'm sure many of you know that 30% of patients have at least one medication discrepancy upon discharge from the hospital. And then 1 in 10 patients discharged home from the hospital experience an avoidable medication-related adverse event within 3 weeks. So really important issue that we're talking about. And then 19.6, almost 20% of patients, Medicare patients, are readmitted within 30 days. So it's a huge spending issue for Medicare spending, and also for quality of life for patients if they're in and out of the hospital all the time. So we focused on these things when we were looking at setting up our program with local hospital. So the objective was to create a sustainable pharmacist-coordinated, patient-centered practice model involving inpatient pharmacist collaboration with ambulatory care pharmacists in the clinic and community pharmacy setting. So the goal is based on those three bullet points in the previous slide. So the goal is to reduce medication-related adverse events, prevent hospital readmission, and improve continuity of interprofessional communication and healthcare delivery. So usually the patient-centered care is the future of healthcare. We think that that's kind of where it's going. We really are striving to do patient-centered care. But the biggest obstacle right now is that everybody's practicing independently. So all these people are helping take care of the patient, but they're really not communicating with each other. They're just kind of circling the patient and helping them out to the best that they know how. So really, we're having a lot of institutional isolation. So these people are all caring for this patient, but we're really not communicating well with each other. And this includes kind of the evolution of our healthcare model. So classic model is basically, everybody's individual silos and kind of communicating back and forth, but it's not being done very efficiently or very effectively. And it's really one-sided. So the hospital is communicating discharge information. We really haven't been able to communicate any information back to them. So hopefully that model will kind of go away. There is an alliance within the Northwest metro area. This was coordinated through the local QIO here, but basically there has been some steps taken to help improve communication between health systems. So clinics and hospitals are really talking to each other a little bit better than they used to and communicating a little bit easier. It's still not a perfect model, but it's a lot better than what it used to be. But pharmacy is kind of on the outside of that still. We're really not being included in that loop of communication, which is a really important piece because pharmacists see their patients very often, and they also can really communicate a lot of information to patients when they're in taking up prescriptions. So our goal was to create this healthcare continuum where the patient's in the middle and we're all talking to each other and all playing the role that we were designed to play, but really optimizing that and communicating well with each other. So the pharmacy's role as medication, Goodrich Pharmacy wanted to optimize medication to provide pharmacy services like MCM and educate patients on their medications. The hospital's goal is acute healthcare management, obviously, medication reconciliation, both at admission and at discharge, and then education about any new disease states that patients may be experiencing during their hospitalization. The clinic is definitely where we do a lot of our coordination of care. We do some specialty referrals on chronic disease state management, and then also a lot of health education as well. So this is kind of our timeline of what we did when we were setting up our collaboration. So in September of 2015, the pharmacist at Goodrich, myself and my resident, proposed a transition of care service to the inpatient hospital pharmacist at Mercy Hospital. So the transition of care service plan was presented both to the clinic and pharmacy or inpatient stakeholders in October. So we talked to them about what we wanted to do, made sure they were on board, and made sure that they were going to support this work. And once we got their approval and their go ahead on the project, we did obtain IRB exemption from both Alina, which is the health system that Mercy Hospital is in, and Health Partners, which is the Riverway Clinic that we were working with. This was really important going forward because it really calmed a lot of fears about the legality of sharing information between non-affiliated health institutions. So it was really important that everybody was on board, and this was the way that we said, yes, look, we have this IRD approval. It's appropriate to be sharing this information about these patients. Then in January, we dug out the process of communicating between both the clinic, hospital, and pharmacy, how we were going to go about doing that. I'll talk about that in a little bit. In February, the clinic schedule was opened, and then in March, we started to see our first patient. So here's our criteria. So basically what happened is we ask that the inpatient hospital pharmacist would identify patients that met some criteria that we thought were high risk for being readmitted. So any of the patients that were admitted to the hospital that had any of the following were then referred to MTM pharmacists on discharge. So if they had greater than or equal to 2 hospitalizations within the past 30 days, greater than or equal to 3 new medications at discharge from a unit, and then any patients that were admitted to the hospital due to an adverse drug event or then referred to pharmacy after they were discharged. So a little bit about the communication. So this is kind of the hardest part, I think, for us in setting up this whole process. So we really wanted to make sure that we could communicate well with each other in the hospital, between the hospital pharmacist and our community pharmacist. So we talked about how we could share this data. And through the Northwest Alliance, there was already some communication happening between the clinic and the hospital. So we decided that it would be easiest just to use this already open line of communication to communicate these referrals back and forth to each other. So basically how this works is that the pharmacist at Mercy Hospital adds an MTM referral note into the electronic medical record in the hospital, the patients who meet the referral criteria. The clinic nurses, so the Riverway nurses at the clinic, receive a list of those patients. So every time a patient is discharged from the hospital, the clinic is notified, and they receive a list weekly of the discharge. The current or the previous way that they were managing this is that these nurses would call these patients, follow up with them, talk to them about what happened, why they were admitted, and then help them schedule any follow-up appointments that were needed. So we thought it would be really a nice, easy, it made sense to have the nurses help the patients schedule the MTM appointments so that we weren't kind of duplicating that work. So we talked to them and trained them in about how we wanted them to talk to the patients about MTM. But basically the nurses are then looking at the electronic medical records that we are given from the hospital and looking for that referral note from the inpatient hospital pharmacist. And then once they see that note, they talk to the patient about meeting with the pharmacist on the outpatient side and then set up an appointment for the Goodrich pharmacist at the clinic. Post-discharge, basically we're doing that full MTM visit that we described at the beginning of the presentation. So we're reviewing all of our medications, assessing them for safety, effectiveness, adherence, appropriateness. And then we also do some chronic disease state management with them. So if there's some medications that maybe aren't optimized for their disease state, we'll help them do that as well. And then follow up as needed and do any further disease state management if needed when we see them during the follow-up. So here's what we're tracking on the outpatient side. So the outpatient side, we're tracking basically these 5 outcomes. So we're tracking a readmission within 30 days, and then also medication discrepancies, both at hospital admission and post-discharge. So those are, both very important terms for medications, and we want to make sure that we're kind of tracking medication discrepancies. We're also tracking how many drug therapy problems or medication-related problems there are during the MTM visit, and then how many visits it was required for us to see them before we thought the medications were optimized. Now, this is a very new thing. We kind of just started seeing our patients, so we just had collected data as of April 1st, and we've kind of only had 1 month's worth of data. So it's a very infant new thing for us, but we just have a little bit of data. So between that, about 1 month's time, 54 patients were screened. So 42 were seen in the ED but not admitted. 12 patients of the 54 were admitted, and 8 did not meet the inclusion criteria. So 4 of those 12 patients that were admitted to the hospital were referred to MTM. 1 was seen by the pharmacist, 1 was declined, and 2 at that time were pending scheduling. So she didn't end up seeing those patients. So we did capture about 75% of those patients that were referred to MTM on the outpatient side. So a little bit about our challenges. So I really just wanted to kind of go through this and kind of the things that we learned along the way in case there's other people out there that are thinking of trying to do some of this work as well. So I think I did talk about this a little bit, and it's really not on here much, but the one thing that we initially had challenges with many years ago was actually reaching out to the wrong people. So it's really important that, if you get a no response or no response from a collaborating institution, it doesn't necessarily mean that it's not going to happen. You maybe just reach out to the wrong person. So that was really an important lesson for us to learn. Other challenges at the hospital level, so there was a lot of legal concern about sharing that data and breaking HIPAA privacy laws and all that stuff. So I think that, like I said before, the IRB exemption really helped ease the minds of the people in legal that this is approved by the IRB and that there is it is okay to be sharing this data when we're actually continuing to care for these patients. The clinic, I think the biggest challenges was stakeholder buy-in. So we wanted to make sure that everybody was on board and everybody knew that we were doing what we were doing. So and that included physician and provider buy-in because it's not, this NPM service and the transition service isn't meant to replace provider follow-up after discharge from a hospital. It's really meant to augment it and make sure that we're really being comprehensive. So one of the things that we found for patients is that the couple that we've seen is that there's a lot of problems that maybe aren't really being thought about. So for instance, we had a patient that, she was seen for, she was admitted to the hospital because she had an acute MI, so she had a heart attack, was discharged and followed up, and actually all her medications were appropriate for her MI diagnosis, but she also had asthma. And her asthma was actually not well managed. She was having a lot of shortness of breath and having to use her rescue inhaler a lot, and she was actually having a hard time distinguishing between her asthma symptoms and chest pain, shortness of breath associated with cardiac causes. So that was one of the interventions that we made when we saw this patient post-discharge. So really, the physician is focusing on what happened in the hospital. Okay, how do we follow up? What do we want to make sure we're monitoring? Well, we're doing that complete assessment of all of their medications. So it's really meant to augment what they're doing. There was also a patient that we saw that was admitted for schizophrenia, and he had scheduled a follow-up appointment with a psychiatrist, but the psychiatrist couldn't see him for 3 months. The hospital gave him medications for 1 month after discharge, so he would have had 0 medications for 2 months until he saw a psychiatrist. So we actually ended up contacting primary care physician and getting him some medications in order to get him through to the point where he saw a psychiatrist again. So it's really kind of augmenting what they were doing and just kind of explaining that process to them. And then the last thing that we had a problem with was Goodrich Pharmacy is not part of that alliance, so how we were going to share that data. So I kind of talked about using the nurses and that communication line that was already open between the clinic and the hospital, and using that to communicate data back and forth between the pharmacy groups. And then patients have been confused about location. So we are Goodrich Pharmacy, we're an independent community pharmacy, but we're seeing these patients in the clinic, so it's a little bit confusing sometimes for patients. We've kind of talked to nursing staff about how to talk to them about that and make sure they knew where to go on the day of their appointment. So just to kind of wrap everything up, so the electronic healthcare records facilitate interdisciplinary patient care at all levels of patient care within this process. So really that was the biggest piece, is kind of that communication line, and that was the biggest barrier that we did overcome. And this product does show that I think we can say that care coordination can occur even between unaffiliated facilities, especially using pharmacists. So pharmacists were used to kind of utilize to deliver that care and to communicate between each other about what changes were made to the medications. The last slide I have is the future initiative. So basically we want to kind of expand that program. So implementing pre-discharge medication reconciliating counseling by the hospital pharmacist, and then expanding the program to include other clinics and maybe long-term care facilities. So that's another place I think that pharmacy can help make sure those medications are appropriate and managed while at transition. And then incorporating other healthcare professionals into that model as well. I think our collaboration with the nurses has worked really well, and I think that there's a lot of other people that we can coordinate with and collaborate with in the future to help improve patient care. Okay, and these are my references, and I think, so that's all I have. So I'm going to now turn it over to Cal, and he can talk a little bit about HIT.
Thank you, Amanda. Yes, my name is Callaway Van Epperen. I'm a clinical ambulatory pharmacist at Frederick in the Medical College of Wisconsin, and I will be discussing transitions of care at Frederick Hospital, focusing specifically on pharmacy services. So my objectives are to quickly review what the current practices are at Frederick Hospital as it relates to transitions of care, and then go into describing current efforts in expanding the transitions of care services, including the development of a new transitions of care clinic, and recognizing that this effort really takes a team-based effort to keep these patients out of the hospital, to keep them healthy. So Frederick and the Medical College of Wisconsin, Frederick Hospital is located in Milwaukee, Wisconsin. We have just over 500 staff beds. It is a 3-hospital health system, with Frederick Hospital being the academic medical center, in addition to 2 community hospitals in the area. We also have 25 outpatient clinics that are most of them are certified patient centered medical homes, a mix of primary care as well as specialty. So Amanda did a great job in introducing this continuum of care, so I don't need to re-explain this to you, but I will be referring to this document or this image in the future. So we've got patients in a hospital state and transitioning over to the patient-centered medical home clinic, and as well as community efforts to help care for these patients. Quickly, I want to talk through what we're currently doing for transition care services at Frederick Hospital. So each of our floors within Frederick Hospital have a decentralized pharmacist working on the floor for the most part throughout the day. And upon admission, each patient will complete a med history and a medication reconciliation done by a pharmacist. And then during the admission, the pharmacists are involved in medical rounding, so they're aware of new medications, adjusting dosages, things like that. And then at discharge, we'll go in to each patient's room, as long as they're being discharged home, and provide a medication reconciliation and education to the patient. So we're talking to them about which of the medications we're continuing, which were changed, which are new, which are discontinued. And then we can also facilitate filling of those new medications at our retail pharmacies. It looks like the text isn't showing up here, but I wanted to also discuss the daily care rounds for, here we go. So the pharmacist is also involved in daily care coordination rounds. So the purpose of these care coordination rounds are to proactively plan for the patient's discharge ahead of time. It's involving multiple disciplinary disciplines, and it's really meant to enhance communication, enhance planning for that day of discharge. So the pharmacist's role within the care coordination rounds is to identify if there's any new medications anticipated at discharge, if there are any medication orders needed at discharge, is there a prior authorization that's needed, are there any time-dependent medication needs that the patient has. Does the patient have prescription insurance? Do they have their insurance card? Where do they plan on filling their medications? And then also if there's any additional education that's needed, say the patient needs to start Lovenox, making sure that they get that education. So in order to further expand on what we're currently doing in the transition of care realm, we decided to do a pilot, which we deemed the Sargent pilot. Sargent Clinic is just next door from Frederick Hospital. And this is to help support further expansion of the transitions of care services, and to focus on the time immediately after discharge. So the Sargent pilot, the purpose of this was to determine if intensive medication and intensive management within the medical home can effectively reduce readmissions into control costs in a very high-risk population, high risk of being readmitted. So the team members that were included within the Sargent pilot include the patient's primary care provider, an APP, in this case a nurse practitioner, discharge advocate nurse coordinator, and a social worker. Both of them, the discharge advocate as well as the social worker, were located within the hospital. A home care nurse, which were kind of the boots on the ground for us, and meeting with patients in their home, and as well the pharmacist. The role of the pharmacist within the pilot was to participate in the daily huddles within the group, and to also participate in a discharge follow-up along with the nurse practitioner. So this was within 72 hours of discharge, the pharmacist would talk with the patient, complete a comprehensive med management, exactly what Amanda was describing prior to. This is what the pharmacist did. The only difference is that this was within the clinic setting alongside the providers. The time frame for the Sargent pilot was 4 months, with a part-time presence of the pharmacist. It includes 22 patients, 108 patient encounters, and the pharmacist was primarily involved with that initial visit to complete that comprehensive medication management. So some of the outcomes, specifically medication specific, there was an average of 2 drug-related or drug therapy problems encountered per patient's encounter, and on average 3 medication discrepancies identified per patient. Overall, there was a readmission rate reduction from 35% down to 12%. It happened that 2 patients were readmitted during the pilot. And there was an overall reduction in cost of 44%. So cost reduced from just under $7,000 to just under $4,000 per patient per 60 days. So as far as conclusions go, with the Sargent pilot, successful discharge involved extensive coordination and communication, frequent meetings amongst the multidisciplinary team members. It was helpful to have the additional care team in the primary care office, as these patients really required frequent contact with the nurse practitioner most of the time daily, and then collaboration with their primary care provider. Most patients were socially complex and needed a lot of assistance from the care coordinator and the nurse practitioner, and the pharmacist visits were really crucial during that initial appointment, completing the comprehensive med management. Team-based approach in providing care for the high-risk patients during the transitions of care was effective, but really, if a member of the team was removed, the whole process broke down, and that was found as an example when the discharge advocate group, which were identifying these patients for the Sargent pilot, that was disbanded, so we no longer had a feeder system, so that the pilot kind of broke down in that matter. So that was a great amount of information and data to help support more of a long-term solution to transitions of care and effectively treating these patients post-discharge. So this allowed us to explore a transitions of care clinic that we named the Hospital Discharge Care Program, or HDCP. We decided to centralize this clinic within the hospital rather than deploying this service to each clinic to be a little bit more economical. So the Hospital Discharge Care Program is a collaboration between Frederick Medical College of Wisconsin as well as Horizon Home Health Care. It helps patients that are at very high risk for readmission to the hospital, and it will provide care for the patient post-discharge for at least 30 days after discharge or until the patient is deemed stable enough to resume care with their primary care provider. So this is an alternative to being discharged back to their primary care provider. It's a clinic that provides additional support and services, and we can work collaboratively with their PCP in keeping these patients healthy. Our primary objective, of course, is to reduce readmissions rates, and I should modify this a little bit and say reduce avoidable readmission rates. There's certainly reasons why patients may need to be readmitted. It's difficult to keep a patient out of the hospital if they're septic, which was an example of one of our patients. So we should maybe modify this objective to say reduce avoidable readmission rates. And then the unique part of our clinic is that it is utilizing virtual visits. So we use Polycom, which is a Skype-like technology. The home health care nurse within the patient's home has the laptop. We connect and we have a virtual visit right there in the patient's home. They're on their couch or their recliner, and we can have basically an office visit right there with the patient. So the new transitions of care cycle, now that we're including the hospital discharge care program, instead of the patient going back and forth between the medical home and the hospital, those that are at high risk of readmission will have their care through the hospital discharge care program, and then after 30 days or having them be deemed stable, then we'll hand them back off to their primary care provider. I wanted to discuss the team members of the hospital discharge care program. So we've got inpatient case managers that are located on each floor of the hospital, and they're identifying these high-risk patients and communicating that to our hospital discharge care program. And they're also contributing to a discharge care plan, and I'll get into that a little bit later. The medical director is also shaping the discharge care plan and will huddle with the team daily. The home health care nurse, like I said, she is our boots on the ground. He or she will complete a home visit within 24 hours of discharge, and then on a regular interval thereafter, will review the patient's medications and is available after hours and on weekends when the HDCP clinic is closed. We have a RN care coordinator who's really kind of the face of the clinic. She's involved in enrolling the patients, facilitating each virtual visit, as well as really a lot of the communication between visits between the Horizon home health care nurse and the clinic and the provider and myself and the primary care provider. So she has a very important role on the team. The advanced practice provider is the provider on the team and also will communicate with the primary care provider. Myself as the pharmacist, I'm completing a comprehensive med management, so I'm assessing each medication for its indication, safety, effectiveness, and convenience or adherence, as well as providing a lot of medication education to the patient and their family. And then we have an MA and a scheduler that will be joining our group very soon, and the definitions of these individuals are pending further definition. In order to identify these patients that may be at high risk for readmission, we developed a tool that we called the HARD tool. So that stands for Hospital Admit Readmission Risk Discriminator. And we have worked to automate this score within our electronic medical record as a column, so it's automatically calculated for our case managers on each floor so that they can easily identify those that may be enrollees to our program. So the HARD tool is a score from 0 to 5. And it involves 4 categories. First category being 2 or more chronic conditions. So those conditions include diabetes, heart failure, COPD, liver disease, dementia, HIV, stroke, peripheral vascular disease, a history of cancer, as well as psychiatric disorders. They'll get 1 point if they have 2 or greater of those conditions. They'll get 1 point if they have 10 or greater medications upon admission. If they're over the age of 65, they'll get 1 point. And if they have a history of frequent admissions, they'll get 2 points. So that's an ED visit within the past, greater than 3 ED visits in the past 6 months, or 1 or greater inpatient admissions within the past 90 days. And being a academic health center, we've got people that help us with work and looking at how sensitive, how selective this hard tool is in really predicting readmission rates. So you can see the hard score tool on the left, and I've got highlighted in yellow the percent that were readmitted for each of the scores. So if they had a score of 2.6% were readmitted within 30 days. 3, it increased a bit to 18%, but 4 and 5, you really see a jump in their readmission rate, 45% for 4 and about 34% for 5. So you can see a pretty significant jump. So those were the patients that we're focusing on were deemed high risk if they score a 4 or a 5 on the hard tool. And you can see on the right the area under the curve for the ROC curve. So a perfect number that we're looking for here for area under the curve is 1. So 0.68 is pretty good. We were happy with this. Very sensitive, very specific in identifying these high-risk patients. So the process of enrolling the patient within a hospital discharge care program, the case managers are identifying these patients early on in the admission, and then reaching out to our clinic and letting us know that this is a good candidate. Then the RN care coordinator will reach out to the patient's primary care provider and get permission for the patient to enroll within the program, as well as get a direction as far as what they would like for any recommendations on the patient's care in the next 30 days. After getting the PCP's permission, the care coordinator will go and meet with the patient and say, this sounds like a great opportunity for you. Your primary care provider is on board for this. And then if they say yes, we'll enroll them within the hospital discharge care program, have their first appointment scheduled before they're discharged. And then we'll also work with the inpatient team to develop that care coordination plan. So here's an example of the care coordination plan that I was referring to. So we have beginning as background in what the hospital discharge care program is, and then just some general information as far as if this patient shows up in the emergency department, you should contact Horizon Home Health Care rather than admitting the patient. And the home health care agency can help to further triage or get a hold of our clinic if necessary. Then we have a brief overview of the recent hospitalizations, priorities for that specific patient, including some barriers and some preferences. So this is kind of our roadmap to provide care for the patient. So in scheduling and trying to organize the hospital discharge care appointments after their discharge, so within 24 hours post-discharge, the Horizon Home Health Care nurse will be going to the patient's home to complete what we call an intake visit. So she's doing all of the assessment that the inpatient physician wanted her to assess, also doing a medication review, taking a look at how the patient is managing their medications at home, and does have the ability to call us an HDCP that day if there's any major medication discrepancies. Within 3 to 4 days post-discharge, really we have a goal of within 72 hours post-discharge for us in the hospital discharge care program to complete that first visit with the patient, and then we'll follow up approximately every week or as needed. We do have the ability to see patients urgently within the hospital, and we're really anticipating about 10% of these visits being the urgent in-clinic visits, and that information is based off of the pilot. And then after 4 to 6 weeks of providing care within the hospital discharge care program, we'll transition the patient back to their primary care provider. So in developing this, we mapped the entire process of when the patient is admitted into the hospital, and then included changes to enroll them within the hospital discharge care program. So we mapped out the entire process so that all players can be aware of how this new process will fit within the existing system. This is the typical virtual clinic, virtual visit workflow. So the Horizon Home Health Care nurse will go into the patient's home and do their initial assessment, get the vitals, then call in to our our technology, our Polycom technology or Skype-like technology, and talk with the RN care coordinator. And the RN care coordinator will get all of that information, then huddle with myself as the pharmacist, and I will meet with the patient virtually and do my comprehensive medication management or following up with that. Then I'll huddle with the provider and talk to them about any drug therapy problems and recommendations that I discovered with my assessment. And then finally we will all huddle together and come up with a care plan and follow-up for the patient. There are many different types of encounters that we're able to do. So, of course, we have that initial intake visit from the home health care nurse. Then we have our new patient visit, which happens virtually, and that's the combination of the pharmacist and advanced practice provider, and that's really what this workflow looks like. So this would be a good example of the new initial visit. We do have the ability to follow up with either an APP-only visit or a pharmacist-only visit or a co-visit with APP and the pharmacist together. We've got the urgent in-clinic visit opportunities as well as, of course, the handoff back to the primary care provider, which is facilitated by the APP and the RN coordinator. Outcomes that we're looking into are readmission, of course, the readmission rate or ED return rate. What are the patient satisfaction? So looking at avatar scores there. How many medication discrepancies are we identifying? And are the patients achieving their individual patient and clinical goals? I've got listed as well the process measures. So how many patients are we identifying as potential enrollees? And then how many are we actually enrolling? What are those barriers? How many visits are APP only versus pharmacist only versus co-visits? What is the show rate, or are the patients allowing the Horizon home health care nurses to get into the home? What are the ratios of internal versus external versus no primary care providers upon admission? What is the overall length of the enrollment within the hospital research care program? And then an assessment of how well our technology is working. So reimbursement challenges, of course, we have the transitions of care management codes that are not planned to be used within our clinic, and we're really supported by cost savings. That Sergeant pilot that we completed in showing those great outcomes as far as reducing readmissions and overall cost savings is what supported the development of this clinic and allowed us to have this innovative virtual visit and not have to be concerned about all of the billing issues that could be involved with such a different type of visit like these virtual visits. So to review the steps in development, we looked at optimizing and sharing the risk stratification tool, the hard tool to identify these patients that are at high risk. We had to build the clinic within the electronic medical record. We needed to communicate with internal and external stakeholders to say this is what we're doing and this is how we're going to do things and this is how it's going to fit in. So that's why that whole workflow that we developed worked so well there. We needed to test the technology in the video visits to make sure that that worked and that we wouldn't be pixelated during half of our visits. And then develop specific workflows for our clinic. Challenges encountered. So we just went live in March and we're getting rolling. We have about 15 patients enrolled at this time and we're planning on increasing our enrollment to a capacity of about 40 patients. So some challenges that we encountered are the stakeholder buy-in. So this is obviously a new step for our case managers to be enrolling patients, so making sure that they understand that. The inpatient pharmacists, I wanted them to communicate if they knew of any issues or barriers or things that we needed to follow up on at discharge, to have them communicate that with me, facilitating that, as well as challenges in communicating and getting the primary care provider's approval. That has been a challenge. Teamwork, who owns which task? So am I, as a pharmacist, going to be contacting the primary care provider regarding X medication issue, or is it the APP, or is it the care coordinator? So defining those tasks. As far as the lab, so where did those results go? So the flow that we had originally was that we were going to give the orders to the home health care nurse, and then they were going to obtain that, but then the results would go to them, and they'd have to forward it to us. So we're still ironing those out, trying to get results fast in those stat labs, as well as weekend lab challenges, trying to get labs over the weekend when the phlebotomist is not working, trying to come up with a solution there. As well as on weekends. So this hospital discharge care program is only Monday through Friday, so trying to enroll patients on the weekends while we're no longer there. We're still ironing that out. So in summary, really information and data is needed to support transitions of care effort. Expansion and team-based care is absolutely necessary to help treat these high-risk patients. Frequent and efficient communication amongst the team members and the patient and the family is essential. And always trying to improve the process, so utilizing the plan, do, check, act, and continuing that cycle to try to improve the whole process is our goal. That concludes my section.
Thank you very much, Cal. We just have a couple minutes left, so I don't believe we're going to have any time for discussion or question and answer session. But if any of the attendees did have a question, as you can see on this slide right here, we have both email addresses for Amanda and Cal, and I feel that they would be more than happy to assist you where they could. And once again, we would like to thank Amanda and Cal for all your experience, your knowledge, and your insights. It's been very helpful in regards to the content today. And if all the attendees could take just a few minutes to fill out the evaluation, it should appear on the right side of your screen right now. It's just a handful of questions, but you completed it. It's your insights and your feedback is extremely valuable and important to us. So with that, this concludes the educational session. Like I said before, just please take a minute to provide feedback on today's session by completing the evaluation on the right. Thank you for spending time with us today. And with that, this concludes today's webcast, and you are more than welcome to disconnect at this time.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.